well in frame and everything ready? When you're ready, doctor. It looks perfect. Perfect, thanks. I think a little bit more until here to be able to show all of this. And to 3, 1, 2, 3. Very good day to all, especially to women because it is International Women's Day. Welcome to this conference. Today we are going to talk about degenerative disc disease. I am convinced that this particular conference stands out as the most pertinent among all others. If you understand it fully, achieving an understanding of 100% will equip you with the knowledge to comprehend approximately 80 to 90% of the degenerative spinal pathology. This includes conditions affecting the cervical, thoracic, and lumbar regions. The latter is the most prevalent and the one we will be commencing with. Furthermore, we will delve into various facets of this topic. We are doing the introduction. We're going to see the development of the spine. We're going to see the normal structure, both macroscopically and microscopically, the physiology, the pathophysiology, the biomechanics that is beautiful in the spine, some clinical syndromes that are related to this, so that we understand precisely what the clinical usefulness is. The spinal hygiene measures that are precisely focused on avoiding all overuse or misuse of the spine. As well as rehabilitation exercises. In relation to the development of the spinal column, it is nothing more than the payment of our spine to walk on 2 feet, to become bipedal. The bipedal position has developed over millions of years in humans and is precisely this, going from a quadrupedal position to a bipedal position. Phylogenetic development refers to how long it has taken for our body to go from a quadrupedal position from one that our primate ancestors had to a bipedal. Position, which is what we assumed in the last thousands of years. In ontogenetic development, it also refers to a development that the human body makes inside the mother's womb and even outside the mother's womb. In the first 2 to 3 years of age, the spinal column changes, knowing that in biological development we have practically a single vertebral curvature, and as embryological development progresses, growth is longitudinal, but actual development of the final vertebral curvatures are acquired at birth, when the baby is outside the uterus and when it begins to walk, precisely at 1 year of age on average. The curvatures that we all know at the level of the spine begin to form, so that in the mature adult spine, there are all the curvatures that we already know. Lordosis, kyphosis, lordosis in our 3 main segments. So the difference between phylogenetic development over millions of years compared to what happens on average a year and a half, 2 years at most, from the beginning of embryological development is exactly the same thing. And remember, we also go through the postpartum period. Before walking standing, we do a 4-point walk, which is the famous crawl. This occurs around 6 to 8 months. So it is the spine participating in all this development, both phylogenetic and ontogenetic. At first glance, we can see that the macroscopic structure consists of practically 3 parts. 1, the annulus fibrosus. 2, the nucleus pulposus. 3, hyaline cartilage, also called the end plate. All this is related to the intervertebral disc, but also do not forget that we have a vertebral body that is everything. And to schematize it, we could be seeing it as a cube with six faces, the anterior elements, the pedicle that joins the anterior and posterior elements, 2 superior facets, 2 inferior facets, a spinous process, and the lamina, which in this projection along with the transverse one cannot be seen. but that is really the macroscopic structure of our spine. But what does each of these contain? The nucleus pulposus itself has a single part, but for the diagrams in the book, they normally always put it in the middle of everything that would be the intervertebral disc. However, it is not 100% in the middle. It is 2/3 behind the intervertebral disc. That is, if we divide the disc from here to here into 3/3, the nucleus pulposus would occupy between the middle third and the posterior third. That's why we'll see later, herniated discs are usually posterior, not anterior. And why are they lateral and not medial? Well, because the thinnest part is precisely these areas, which is the lateral part. The nucleus pulposus is practically water, today as we know it. While the annulus fibrosus, right now we're going to see its biochemical composition, but there are 6 layers, 1, 2, 3, 4, 5, 6. 1/7 layer here. Notice that the curious thing is, the arrangement of the layers are assembled at inverse angles. That is, while the previous layer goes to one side, the layer that follows goes to the other side, and thus forming different angles between the 7 layers. That is the annulus fibrosus. Different layers of it, the annulus fibrosus and the nucleus pulposus occupying the posterior part. This is from the microscopic structure where we see that precisely the previous drawings are taken from Kapanji's book, an excellent book on joint physiology that names these layers since then. And microscopically, because here we are seeing the 7 layers of the annulus fibrosus, the thinnest area, the nucleus pulposus, is considered like a viscogel. That's what they call it. The thinnest part of the other side, and the entire annulus fibrosus in general. So here we are looking at the now microscopic composition. We will find all these elements in the intervertebral disc, both in the annulus fibrosus and in the nucleus pulposus, but mainly this element to which we owe life on this planet, planet Earth. Water today is the main content of the intervertebral disc, especially the nucleus pulposus. But we also have tropocollagen, we have chondrocytes, we have fibrocytes, and we have chondroitin sulfate. All of this comes together so that we can now see what the microscopic percentage composition of a normal disc is, both in the annulus fibrosus and in the nucleus pulposus. We're going to see how much and what cells. We're going to see how much water, protein, glycans, and how much collagen they have. Let's start from the outside in with the annulus fibrosus. So what cells does it have? Well, it has fibrocytes. 60% of the annulus fibrosus is water, while 10% are protein glycans. But we need a substance that provides enough resistance. That resistance is given to us by 90% of the collagen that the annulus fibrosus has. While in the nucleus pulposus, instead of fibrocytes, in the nucleus pulposus we will have a few chondrocytes. It's really not a large amount, but what is relevant is the 80% of water contained in the nucleus pulposus. But who keeps that water inside? Who is in charge of keeping the water inside? Well, the protein glycans are precisely in charge. Protein glycans practically constitute half of the content of the nucleus pulposus. The other half is collagen. The other half is collagen. And then you realize this is the viscogel that we are considering. It is the shape or the state that the nucleus pulposus is in. But is not like that our whole lives. When we are approximately 10, 15, 20 years old, that 90% of water is conserved within the nucleus pulposus. But as we advance in life, from the age of 70 years onwards, under normal conditions, only 60% of water is found. In such a way, we are talking about physiological dehydration within the intervertebral disc. Remember that here, the proteins, the polysaccharides, create an osmotic pressure, allowing water to arrive, and this is known as hydrophily. Thanks to this, they create an osmotic pressure due to inhibition. The intervertebral disc is nourished by attracting or maintaining water within the nucleus pulposus. Why is it more common to find herniated discs in the lumbar region than in the dorsal region? Well, it happens that in the dorsal region, in the thoracic region, the disc to vertebral body ratio is 1:5. That is, they are very small intervertebral discs in relation to the disc, to the vertebral body. Furthermore, if we consider that the thoracic vertebral bodies have greater stability thanks to the rib cage, ribs, sternum, and clavicle, this allows us to have practically absolute stability here. Change in the lumbar region, we have a proportion of the intervertebral disc in relation to the vertebral body of 1/3. So we are already talking about an intervertebral disc much larger than the previous one. Something similar happens in the cervical region. It is 2/5 in relation to the vertebral body. Here it is also common because they are the two areas, both the lumbar region and the cervical region, are the two areas of greatest mobility in our spine. What happens under normal conditions? All these images are from Kaponji, Joint Physiology. Magnificent. They are all in black and white, and I respected them just so to be able to talk, because they are very, very illustrative images. Above we are seeing what happens here in this region, when the intervertebral disc under normal conditions has axial compression. Under axial compression, what happens here in the nucleus pulposus? Water comes out, water comes out, water comes out. It migrates through the plate terminal, and this causes the interbody space to decrease. But what happens when we then remove the axial load? When the arrows are up and down, we are removing the axial load. The only way this can happen on Earth is by lying in our most comfortable bed, or by being in the water, in a pool, in the sea. We take the axial load off the spine. And then what happens to the nucleus pulposus? If you notice, all the little arrows go inside the nucleus pulposus on both sides, and here the nucleus pulposus is rehydrated. Then with axial loading, it dehydrates. By removing that axial load, we rehydrate our nucleus pulposus, but not for our whole lives is going to happen here. Here we have precisely in this bar, in this shaded bar, the height of the interbody space, the height of the disc space under normal conditions. In this first diagram, we see the healthy disc, which is at rest. That is, it has no axial load, it is resting, it is lying down, which is the best way to take load off our spinal column. While in the second scheme, we are adding 100 kg of weight. With 100 kg of weight, it decreases. Our inner body space to 4 millimeters, our intervertebral disc under load. But in healthy conditions, that disc recovers again. That 4 millimeters that are lost during weight bearing recovers again as long as it is healthy. When it is no longer healthy, that the disc is already beginning to dehydrate, that the nucleus pulposus no longer has as much water, that the annulus fibrosus no longer has as much collagen. If we load it with the same weight, the same 100 kilograms, already it's not going to decrease. Four millimeters. Now it will decrease 2 millimeters for each intervertebral disc. And then this increasingly damages our intervertebral disc. There are some positions that we never realize. We adopt them throughout our lives, throughout our work and daily use of the spine. But here we are precisely going to illustrate in kilopons, which is still the original measurement that the author gave us to contemplate the intradiscal pressure that was measured when being in different positions. And we're going to start here at 120 kilopons. When we are standing, that is standing, we have a load on the intervertebral disc. If we are sitting, we also have a load, but we have even more load, up to 120 kilopons. If we are standing and have a forward flexion of the spine, it rises to 200 kilopons. And if we add weight, it is the weight of the object plus 240 kilopons that will be quantified of pressure at the level of the fifth intervertebral disc. Towards the left, we have the pressures that are exerted in other different positions. For example, driving in a comfortable position, roughly at a seat angulation of about 30-40 degrees, the intradiscal pressure decreases to 80 kilopons. If we are lying down and flexing our legs, the intradiscal pressure is 40 kilopons. If we are lying down without bending our legs, it is practically the same, but we can get as close as possible to being at 0 kilopons of intradiscal pressure. So all this is already a preview. Why spinal hygiene measures? What are the spinal hygiene measures? Why do we have to follow spinal hygiene measures? Because to our right, we have all the positions that cause disc dehydration. There is axial compression, there is increased intradiscal pressure, and therefore they become dehydrated. While on the left, we then have a rehydration of the nucleus pulposus, and therefore they are positions that we are considering are healthy for our spine. Unfortunately, on this planet, where we have the action of gravity, we cannot lie down all the time. We must also have physical activity. But right now, we are going to see how else we can compensate for it. In such a way that these have to be imagined as when we throw a stone into a pond of water. This stone makes different waves, and we start with very strong, very large waves, and little by little they fade towards the periphery. This is exactly what happens if we have an axial load on our nucleus pulposus. These waves are dissipated homogeneously by the nucleus pulposus in healthy conditions, in conditions of good hydration. What happens when we give the same axial load but the nucleus pulposus is no longer well hydrated? Our annulus fibrosus no longer has the amount of collagen that we usually have under normal conditions, and then the energy is dissipated, but in a heterogeneous way, in such a way that this still continues to hurt the annulus fibrosus much more, and a disc degenerative process begins. The problem is not only in the front in the nucleus pulposus and in the annulus fibrosus, the problem is also in the back. In the facet joints, we also have the same changes that we will see in a moment. And then precisely this author, Kilcaldy Willis, since 1978. And it seems like many years. Perhaps it is, but it's still valid. It is still valid, and he has told us since then about the cascade of disc degeneration. If we can understand this 100%, we will be able to understand what exactly disc degeneration refers to. He told us about a three-joint theory. Obviously, the joint in front refers to the intervertebral disc, and the joints in the back refer to the facet joints. Both anteriorly and posteriorly, there will be an infinite number of pathophysiological changes that will lead us to the process. But if you notice, this process is divided into three parts: a green line, a red line, 3 parts. In the first part, in the first phase, we are going to have circumferential lacerations of the annulus fibrosus in a scheme that I'm going to explain next. I'm going to explain to you what this term circumferential lacerations refers to. But in general, it is in the same direction as the collagen fibers of the annulus fibrosus. But in the posterior joints, there are also changes, and there begins to be a synovial reaction, a synovitis, which obviously either of the two causes pain. That is why in this first phase of disc degeneration, which is up to the green area, it is considered stage 1, or stage of inflammation. Inflammation. In stage 2, which is from the green stripe to the red, we have changes posteriorly. That if all this continues, remember that this is a natural history of the disease. All this continues, it will no longer be just circumferential lacerations. Otherwise now they will be radial lesions that go from the center to the periphery. And precisely in this phase is where we have the emergence of herniated discs, hernias of the nucleus pulposus. Posteriorly, in the facet joints, there will be a destruction of the articular cartilage, and this will also cause the formation of osteophytes. If here, in this phase 2, which is the instability phase, a herniated disc does not occur, this can continue. It can continue. Remember that it is a cascade phenomenon, and if we were lucky not to have a herniated disc, there will now be internal tears. And we move on to phase 3. Phase 3, which is the stabilization phase. Stabilization, because behind there will already be a laxity of the ligamentus, a subluxation that will cause joint hypertrophy, hypertrophy of the laminae, and then the appearance of even more osteophytes that even cause it to fuse and decrease the mobility of the interbody space. Anterior to the intervertebral disc, there is a loss of height. If we are observing that the intervertebral disc is dehydrated, obviously the height of the interbody space decreases. Many of the elements begin to be reabsorbed, especially the water in the disc space. There are more osteophytes. Not only posteriorly are osteophytes, but also anteriorly there are osteophytes. And this causes us a disease that we also know perfectly well, which is narrow lumbar canal. Narrow lumbar canal is the same degenerative disc disease, but now in phase 3, or a stability phase. This is phase 3, or stability, and this can be on 1, 2, 3, or multi-level. It can be in the cervical region, it can be in the lumbar region, which is the most frequent, and very, very exceptionally in the thoracic region. What is radial tear? Radial tearing, before it begins with these small circumferential tears, following the trajectory of the fibers. One layer is torn, another layer is torn, another layer is torn, all 7 layers are torn. When these join, then radial tears come. And the radial tear is the union of the circumferential tears. What if we already have a radial tear? Well, what is going to come out of there? When we already have a radial tear, what comes out is precisely the nucleus pulposus. And this is the pathology known as herniated disc. It is part of a degenerative process that we are now going to see from a clinical point of view. Up to this point, nothing significant would happen, nothing more than lower back pain if there were no elements that cause us pain. Those elements that cause us pain because they are precisely the roots of one side and the other. When we have a hernia here and there is root compression. That is the reason why our patients come for consultation. What is the composition of the intervertebral disc? Already in conditions that are not so good, not at 100%, and when there's a degenerative process, if we compare the amount there is, the percentage that I had already mentioned in normal conditions with those of now, in a degenerative process. Well, we are going to see that mainly the water that we already discussed decreases completely. The cells that were present, especially in the nucleus pulposus, which are chondrocytes, also practically disappear. Chondrocytes are the main changes, and these occur both in the nucleus pulposus and in the annulus fibrosus, where above all, collagen can drop to 50% or sometimes present few changes. It is a degenerative process. There will be human beings who are affected by the degenerative process in the cardiovascular system. There will be other humans who are affected in the genitourinary system, in the integumentary system. Others will be affected in the musculoskeletal system, long bones, large joints, hips, knees. Or there will be people who are also affected in the spine, which is the issue we are looking at here. They are cadaveric sections, where we see precisely up here the normal conditions, the normal height of an intervertebral disc, how the nucleus pulposus is seen perfectly well defined in its viscogel consistency. But when we have it in conditions with a degenerative deterioration, we see that there are already internal ruptures, that the interbody space decreases, that there is no longer hydration, that practically the nucleus pulposus that was previously seen here disappears. And in the image on the left too. What does body weight have to do with it? And this is part of the interesting biomechanics. Here we have the lumbar spine subjected to 3 forces. Remember that all this is based on the parallelogram, and finally the resultant. It is not the force of a single muscle. It is the result of the force of several muscles that all combined are exerted in the same direction. So here we are going to see, for example, the force M. The M force refers above all to the rectus abdominis muscles, but they are not the only ones, as I explained. The oblique muscles also have a lot of influence here. In force M, we are going to consider the muscular strength of all the thoracolumbar muscles, all of them, absolutely all of them, and the public force. What do you think the P force refers to? The P force effectively refers to our own body weight, that is, head, trunk, abdomen, and we are only going to remove the weight from the pelvic extremities. All that is what we are going to load here. And then how are these forces going to combine? Or how are these forces going to balance? We have to think of this as if it were precisely a construction crane, which we see very often constructing buildings. Well, our spine acts very similar, where everything is a lever arm. All the tension cables of the cranes, in our case, are the vertebral muscles, both posteriorly and anteriorly. Here we also have cables that are the rectus abdominis muscles, or the pectorals, in the case of the chest, of the thoracic spine. And in this, we have our arms that are going to take on an effort. The compression exerted on the spine is equal to the weight we are going to support. If we want to pull 100 kg in the gym, well, that has to be multiplied by the distance between the weight and the spine. That is from this to this. If we do it with our arms more stretched, the possibility of damaging our spine is greater. If we load more weight, it is greater. So, the strength we have in the paravertebral muscles and the anterior muscles of the spine will depend a lot on this, explained in newtons. Now, how can we do it? Above in this diagram, we are looking at the muscles, the force exerted by the deep muscles of the back. In this diagram, we are already seeing the forces that are exerted solely by the fact of having flexion of the thoracolumbar spine. But now we are going to carry 90 kilograms plus our own weight, which is the body weight above the pelvis, removing practically only the pelvic extremities. It is calculated in an individual of 70 kilograms more or less corresponds to 36-37 kilograms. If we add these two things together, then all of this will give us 8.2 newtons of effort, so that we can compensate for these two forces that we already have here converted to newtons. in such a way that in order not to damage our spinal column, we need an effort of 9.2 newtons. What are we going to do for it? To do this, we can increase intra-abdominal pressure. If we increase the intra-abdominal pressure enough, we can add to this force and now compensate it 810 newtons, which then decreases from 8.2 newtons of force that we are going to need 9.2 newtons in the spine. We lower it to 6.6 newtons. Specifically, how can we exemplify this? 2 ways. 1, all those who practice weightlifting, those who lift weights in the Olympics, if you notice, use a very wide belt and adjust it to the maximum. When they go forward to lift that weight, what are they doing? They are increasing the intra-abdominal pressure, which is calculated in millimeters of mercury. It can reach up to 148 millimeters of mercury, and they are doing it artificially. How do we doctors do it? At the moment that we give a prescription to the patient in the office, we prescribe them a lumbosacral belt. With this, we increase intra-abdominal pressure, and the patient feels more comfortable. But what do we really have to do? What we really have to do is strengthen the abdominal muscles, lose body weight, so that this can be useful. And this is precisely what we're going to see right now. You have to know how to lift objects from the floor. Never in this way. Remember the intradiscal pressure that is generated, always bending the knees and the object as close to the center of our body as possible, as we also discussed in biomechanics. Rehabilitation exercises all carry the idea of improving muscle tone in both the posterior region and the anterior region. The exercises can be done even in your own bed. You can even do some water exercises. It is a very common mistake that the doctor sends the patient to swim, sometimes out of laziness, sometimes because we do not really know what the aquatic exercises are, but it is not really what we want for the patient to go swimming. Many of them do not even know how to swim, so we have to teach them how to do exercises in the water, aquatic exercises. Exercises in bed are very simple. Everyone has been taught since primary school, flexion, extension of the knees, which all of this are called lower abdominals. Lower abdominals because it is with the legs that the abdominal rectus muscles will act. And all of these keep the spine in a neutral position in such a way that they are not the boxer abdominals, the usual ones. Yes, they can hurt the spine if you do not have good physical preparation. You can find aquatic exercises by typing this term in any search engine, and they are very simple, all with goggles to prevent water from entering the nose or eyes, and to be able to do push-ups, be able to grab a polyurethane tube, bend it in a V shape, swim on your back, swim on your front, kick your feet. We don't really need the patient to be an Olympic swimming champion. We need him to exercise in the water. Why in the water? Because remember, that is where we remove the force of gravity from our spine. The spine works less and is injured less, and our body can exercise. Here are more aquatic exercises, all of them on the edge of the pool. This is simulating the edge of the pool. Here we are in the corner of the pool, so we don't even really need to swim, but rather do exercises in the water. For your attention, thank you very much.